Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, Anita Finley.
We're going to find out if you have a hurt knee, really badly hurt knee, what should you do with it? We're going to find out what happens when you're a tennis player and you're having all these really big problems with your knees and what you should do about it. And the only way to do that, really, is to talk with a board-certified orthopedic surgeon. And we're so fortunate to have Dr. Minn Saing in our studio today. And when I say Saing, it's spelled S-A-I-N-G, but it's really Saing. So welcome to our show, Dr.
Thank you
Saing.
very much. Thank you for having me.
Yeah, it's great. And see, we have kids, just as you have children, and I have grandchildren, and just one weird little thing happens. They slip and they fall, and now it's really a big deal. Because you are one of the young orthopedic surgeons who probably didn't know years and years ago how hard it was and people were kept off their feet for months. And now it's pretty easy, isn't it?
You're absolutely right. Things have changed a lot. Technology has caught up. And our goal as orthopedic surgeons is to try to pick the right treatment. And we have all the modern technologies available to us to try to get you back on your feet as soon as possible.
I know my husband has two new knees. He's had them for 25 years.
Wonderful.
They still work.
Wonderful.
And he has had a lot of hips. He is 92, but he's in great shape, and that saved his life because you can imagine years ago, you just put someone in a wheelchair, and that's their life.
You're absolutely right. Joint replacement has really come a long way. The technologies in terms of manufacturing the metals now make the implants last longer. People can be more active on their joint replacements. And even outside of joint replacements, there's been a lot of technologies to try to preserve patients' own knees to try to keep them more active and more happy.
So what would you advise? Now, you have young children. Is there something you could start doing with your children that would keep them? I mean, is there certain kind of vitamins or are there certain kinds of care they should do to prevent these falls and hurting themselves so badly?
I don't think specifically that there's some magic answer to that. I think that kids will be kids. They're going to play sports. They're going to fall down and they're going to get hurt. And that's where we come in. I think as parents, we kind of have to let kids be kids. But of course, we want them to play their sports and do their activities as safely as possible so that everybody has a good time.
I just had an author on my radio show, Dr. Saing, and her husband has Alzheimer's, and he keeps falling.
Yes.
And he keeps breaking his hip. I don't know what you can do about that one.
That's a difficult situation, particularly in more elderly patients who have dementia. They can be a fall risk. And with that, certainly you can break a bone, in particular your hip or your wrist or your humerus. So these are tough injuries. These are tough patients for us to treat, particularly because they are a fall risk.
And something that I've just heard now, when my husband has had his surgeries, they used anesthesia. But now they're using epidural. Aren't they using something else?
Well, you're right. But a lot of times we will use some degree of anesthesia. But in addition to that, we sometimes use regional or a nerve block, which will kind of numb that extremity. And usually we use that in conjunction with general anesthesia.
Because we all know that the anesthesia is very hard on an older person. They don't come back as quickly with their brain.
Yes, absolutely.
So you're very aware of doing that. And I'm glad now that's something new because it wasn't that way before either.
Right.
And yet when you look at really old films, I don't know, these are documentaries back in World War I or something, they didn't even use anything. I mean, they just, I don't know, those poor people.
Right.
They just.
I think they would use ether, ether and a shot of brandy, and a wooden stick to bite on. So you're right. We've come a long way in terms of pain management, in terms of our anesthetic techniques, and then also as well as in our surgical techniques. Incisions have become a lot smaller. The technology is caught up in allowing us to do surgery through smaller incisions. That's kind of something that I am a specialist in. I do arthroscopy, which is surgery that's done with a scope. And so we make tiny little keyhole incisions. They're so small that you can cover them up with a Band-Aid.
And tell us what that's for.
So the surgery that I specialize in is arthroscopy of the knee as well as arthroscopy of the shoulder. So we can treat a multitude of knee conditions and shoulder conditions through very minimally invasive techniques.
Why would I come to you for that? What would be would I have a painful knee? What's happened inside?
Absolutely. So you could be experiencing a painful knee. You could be experiencing mechanical symptoms where your knee gets stuck. You may have had a sports-related injury where your knee came out of place. Just yesterday in clinic, I had a Royal Caribbean dancer who landed awkwardly and the knee dislocated. And so they came to me and they're going to require surgery because they tore their anterior cruciate ligament. So any kind of knee injury or shoulder injury where conservative treatment hasn't helped, then you might want to come see an orthopedic surgeon to see if there are some other, not necessarily surgery, but maybe we have some other tricks up our sleeve.
Right. And of course, we always think of the bionic man, with all these things that you just function on a computer. But are you doing robotic surgery at all in any of these areas?
Me personally, I don't do robotic surgery, but certainly in orthopedics as a field, there is robotic surgery, in particular in the knee. There are some doctors out there that are doing robotic knee replacement surgery.
And why have you chosen not to?
That's something that is still fairly new. And if you look at the results, they're pretty comparable to doing them without the robot. And so the
robot's expensive.
Exactly. And nowadays with medicine, it's not just about the medicine, it's also about the cost of medicine. That's something that we as doctors have to try to contain. Is it cost efficient? Is it something that, we can do and make a profit? Or is it just a marketing tool? And it's a fine balance. So personally in my hands, I've been having good results without the robot. But that's something, that certainly I could consider in the future.
So when you were growing up, what were your toys like? Is this something you wanted to always do? How did you know this?
I think I had a lot of influence from my father. My father was a pediatric surgeon. So, and I grew up with a family of doctors. My aunts and uncles were also doctors and surgeons. And so that was kind of
said, yeah, kid, you're going to be a surgeon. Yeah, but then you had to make a choice.
You're absolutely right. So I actually personally tore my own ACL. And that was in college. And
tell everybody what the ACL is since you told me.
Right. So that's your anterior cruciate ligament. That's the main stabilizing ligament in your knee. And in particular, if you're young and active and you want to play sports, it's something that we recommend that you have fixed. And so I injured my ACL playing basketball, and I had it fixed in college. And that was kind of when I already knew that I was going to be pre-med and go into medical school. But that's when I really started getting interested in orthopedic surgery.
Tell me what that looks like when you open up my knee to do that.
The good news is that I don't have to open up your knee, right? So I do the surgery arthroscopically, which is through the small little holes in the special scope. And so it's almost like not quite like playing a video game, but your knee picture is shown up on the screen. So
I see. So you're able to at least see it. You don't have to go in there, but how do you know it's going to work when you get finished? That's so funny to ask. I mean,
we test it. So there are many different techniques to fix an ACL, but essentially the ACL ligament, the anterior cruciate ligament, doesn't grow back. So what we have to do is replace it with another ligament. So sometimes we take it from the patient themselves. That's something we call autograft. Or sometimes we take it from a cadaver, somebody who's donated their body to science, and that's called an allograft. And there's different ways of fixing it. We can fix it with buttons. We can fix it with screws. There's metal screws, bioabsorbable screws. So there's lots of different ways or techniques that we can fix it. Once it's fixed, we actually test it. We will examine the knee to see that it's stable.
I'm glad you mentioned the cadaver because my husband and I are part of Science Care. In Science Care, they take our body when we die, they pick it up,
Yes.
and we go and we can be a cadaver. They can use our parts. And I have spoken to a lot of doctors. They say, we loved our cadavers. We celebrated them at the end of our semester.
You're absolutely right. So some cadavers will go for education, medical education, and surgical training. And you're absolutely right. They are essential for learning gross anatomy. They're essential for training the future of our medical profession, the young doctors coming up. And they're also essential for training surgeons that are already out in practice on new techniques. And they're also essential for providing the grafts that we use to treat patients that are currently living. So cadavers are essential for the future of medicine, yes.
Right. I'm very excited about the fact that I'm not going to be just put down in the ground or burned up or do something that I'm going to have some use after I die. So that's been very important to me. I'm glad you mentioned the cadaver. Well, you had some excellent training all over the country, really, and Philadelphia is where you were. There are a lot of people who are getting into this field, and some people are not specifically sports medicine; they're just general. And so the difference is you would take care of anybody, but you specialize, so you know a lot of what happens in the sports field. Is
right.
that the difference?
So the way orthopedic surgery works is typically after medical school, you will match into an orthopedic surgery residency, which is 5 years of training. And in that 5 years, you have 1 year of general surgery and 4 years of general orthopedic surgery. So after that residency, you're technically a qualified general orthopedic surgeon. At that point, a lot of surgeons will decide whether or not to take on a fellowship, which is what I did. So I took a fellowship in sports medicine, arthroscopy, and cartilage reconstruction in Atlanta. But there's different fellowships out there. For example, spine, trauma, hand and upper extremity, shoulder and elbow, foot and ankle, total joint replacement. So these are all fellowships that surgeons will choose to take. And then once they finish that fellowship, they're now fellowship-trained surgeons in that particular specialty.
That's a very good point that you just brought up. So if someone's having a serious, problem, orthopedic problem, it's probably better to find a fellowship-trained person in that area.
Yes, if they're having a particularly difficult problem, a lot of general orthopedic surgeons can take care of a lot of the bread and butter problems that we see, the typical fractures that we see, the typical joint replacements that we do. So a lot of general orthopods, especially perhaps maybe not so much in the urban communities, but that are in more rural communities, that's where you'll find a lot of the general orthopedic surgeons. And when you get into more urban areas, then you will find a lot more specialty trained doctors, and it's almost become one joint, one surgeon. And you'll find that in a lot of practices. In our practice, for instance, we essentially have fellowship-trained doctors that cover each particular specialty, be it hand, be it joint replacement, be it foot and ankle or pediatrics. We try to take care of everybody in that regard.
Yeah, I think if I had my druthers, I'd rather go to someone who specializes in something because they've seen a lot of it. They know specifically.
Right. That's usually what happens as a fellowship-trained doctor. You tend to become very experienced and skilled in your field. So, for example, even though I do general hand surgery, if you had a very complex hand problem, I would refer you to see a hand specialist because that's what they do. That's what they got their fellowship training in.
Yeah. That's interesting you should mention. We did have someone on our show and was doing our Cure Symposium who was a hand specialist.
Yes.
And it was amazing, all the things he talked about.
Yeah, it's amazing what they can do with the hand.
Yeah, especially now prosthetics also.
Absolutely.
That's coming in so strong because of all our military coming in. So, but let's just go into some of the, I know people have talked about rotator cuff surgery. And
yes.
How do you know you have a problem with your rotator cuff? Your arm just hurts or what?
No, it wouldn't just be simply pain. Usually when you have a complete tear of your rotator cuff, a lot of times people can associate that with a traumatic event. So they maybe were moving some furniture, maybe They fell awkwardly. And then they felt some immediate sharp pain in the shoulder, and after that they were unable to use their shoulder properly. The rotator cuff is a set of muscles within the shoulder that are responsible for a lot of the overhead activities. So a lot of people will say, I can't reach my hand up, or I can't reach overhead for this particular thing on the shelf, and that it's also associated with pain. So when you have that story and then the symptoms and the two match, that's when you can start to suspect a rotator cuff injury. Now, certainly people, just from wear and tear and general aging, can also wear out their rotator cuff. I always try to tell my patients, you want to imagine yourself as a machine. And as we move on in our years, well, that machine is also moving on in our years, and all of the moving parts in the machine are also wearing out. So you can get some degenerative tearing of the rotator cuff, and that simply happens from being alive.
You have to keep it well oiled, right?
Yes.
I want everyone to know my guest is Dr. Minn Saing, and he is he has his own organization, and they are called Orthopedics MD. I'm sorry, MD. It's Orthopedics, DIX, MD. But the reason I'm even having him on the radio show is because I work very closely with Broward Health Imperial Point, and that's where I believe that you do a lot of your surgery.
Yes, I do.
They're a very wonderful hospital.
Wonderful hospital, great staff, excellent patient care. I've been very happy with my time at Imperial Point and hope to stay there for a while.
Yeah, no, they're excellent. I was thinking about, can you describe verbally, so people will think about, what does a rotator cuff look like?
Well,
why do they call it rotator cuff? It rotates?
You're absolutely right. So it's a rotator cuff muscles are a group of muscles. There are 4 muscles. And if you imagine your shoulder joint almost like a ball sitting on a saucer, the rotator cuff muscles will come around and attach on the ball. And what they do is they're responsible for moving your arm into that overhead position. It's kind of the best way I can describe it.
I think people see when we have our symposiums, I have doctors such as yourself bring the mechanisms
model
and everything.
Yes,
because people say, I just had a rotator cuff surgery, or I had this surgery. I've had orthopedic surgeons bring the knees, the hips, all the things that they have to insert.
It's much easier to visualize with the model. You're absolutely right.
Yes, but you did an excellent job with that, because it is, I have to say, there are a lot of people who complain of rotator cuff, and I don't know if they're just elder people or not, but so someone would have to have a problem. I remember once I had a hard time raising my arm, but then I wound up having some laser treatment, some cold laser, and in about 3 treatments, it went away. Mm-hmm. So that wasn't probably as serious. I mean, I haven't had anything happen since.
It probably wasn't that serious.
It's a sprain. I guess it's like a sprain.
Correct.
Right?
I mean, and also shoulder pain could be a lot of things. You could be having some arthritis within the shoulder, which is very common. Everybody gets arthritis. It's the same story. It's wear and tear, and as we move on in our years, we get wear and tear in all our joints. So that's arthritis pain. It could be some inflammation. So you could just have some tendonitis or some inflammation of the tissue that's surrounding the tendons. And usually these kind of problems with some conservative treatment, so not surgery, they will go away on their own.
All right, so now this is, I'm sure as a surgeon, I mean, this isn't into surgery, but you'll know. People don't know when they fall and they hurt themselves, should they put ice on it or should they put heat on it? And I'm going to really pin you down on this.
Well, that's an easy question.
Oh,
so,
good.
okay.
So what?
So as soon when they fall.
Okay. I've just fallen.
You've just fallen.
Yeah.
Yes. Ice is definitely recommended.
Okay.
Okay. Because
for how long?
Well, for the first 2-3 days. Okay.
Oh.
Yeah. You would ice it because that initially when you have a fall and you injure that joint, be it your shoulder, your wrist, or your knee, it's going to start an inflammatory response. And that's where the ice comes in. The ice helps to kind of calm down any swelling, and it also helps with the pain. So when you first injure yourself, it's always the ice. And that's why you'll see on the professional sports, the football players, you'll see them when they get hurt and they're walking around on the field with that big bag of ice. Heat comes in later on.
And what does the heat do then?
The heat is really
Is it for healing?
Yes, you're absolutely right. So in the healing phase, you want to use heat because heat promotes blood flow. And so they'll use that later on in the treatment of the injury.
So you don't want heat when you first have this happen.
No, it's always ice.
Because that's going to make more inflammation, isn't it?
Correct.
See, I'm getting my course right here with you. I knew that. Yeah, that's, people, especially as they age, they really do want to be careful because a lot of them want to exercise,
Right.
but they sometimes they can exercise incorrectly. That was another thing I wanted to talk to you about.
Yes, yeah. So, I always encourage everybody, all of my patients, all ages, to do a couple things to help prevent injury. And one of them is pre-activity stretching. So I always tell patients, listen, if you're going to be working out, if you're going to be playing tennis, if you're going to be playing a round of golf, take 2 minutes before you start to stretch, be it your back, your shoulder, your arms, your legs, your calves. And there's been plenty of literature to show that pre-activity stretching lowers your rate of soft tissue injuries. These are the common sprains and strains that we all experience. And so I think that's one useful tip that I have for all the budding athletes out there is to stretch before you play.
I have a little dog,
Mm-hmm.
and when that dog wakes up, that dog stretches. It goes up.
It's
it
almost
goes back.
instinctive for him, right?
It is.
Yeah.
It's interesting that, and then every time they get up from a nap, he gets up from a nap, she gets up from a nap, excuse me, you can see her back goes up, her legs go out, and that's what she's doing. She's stretching.
She's stretching, yeah.
And so there's really something to that.
Absolutely.
Well, I think that if people were listening now, you would know that Dr. Minn Saing is an orthopedic surgeon. You can find him over there at Broward Health Imperial Point. And if someone wants to get in touch with you, I really don't have let's see, you have a website? Would it be the orthopedicsmd.com?
MD.com. Yes.
Okay, and they could ask for you. And
Yes.
I will give a phone number, too, in case somebody wants to. The phone number to call would be 954-580-4080. 954-580-4080. Well, let me also talk about people who are in rehab.
Yes.
Because rehab's extremely important. Now, here you've done all this work. You're sending them away. They're in the hospital maybe a day or two. I mean, you are really amazing how fast you move them out.
Right.
But those physical therapists are extremely important.
Absolutely. They're critical to our outcomes. And it impacts all orthopedic surgeons. It doesn't matter what the surgery is, from your fingertips to your toes. Physical therapy after surgery is critical. And we all encourage all of our patients to do it. Sometimes it is difficult with our busy lives. A lot of times the therapist will work with them to give them home exercise programs, but therapy is critical to outcomes.
And why is that?
Well, therapy helps with motion. So a lot of patients after surgery, they may not want to move their arms on their own or their legs on their own. So the therapist will actually move it for them. And the therapist will teach them exercises that are less painful, that the patient can feel safe doing, to help with those motions. Therapists will also help with strengthening. So the therapist will teach them exercises on how to activate those muscles and do it in a safe way. And therapists also help with things like scar and swelling. They can
Scar and swelling. What's that?
Absolutely. Well, particularly in hand surgery, for instance, they'll even massage the incision to help mobilize the scar. Okay, they'll do that on the knee as well. And then also they'll, just with swelling, moving the joint is going to help with swelling. They'll massage and also ice the joint. So they'll do a lot of tricks. They use ultrasounds. They have all kinds of gadgets and machines in the therapy gyms to really get patients moving and try to get them back on their feet as soon as possible.
So if you took a patient who didn't have therapy, you did a great job on your surgery,
right?
And then you took a person, same thing, and and then had a great therapist, a physical therapist, what would happen?
Well, every patient is different,
Well,
but in general, I would expect the patient who had the therapist to do a lot better. I would expect them to get their motion faster. I would expect them to return to their regular activities of daily living faster. And overall, I would expect them to have a better outcome and have higher satisfaction from the surgery.
But of course, and I haven't had any surgery like that, but I would assume there's a lot of pain. And so that's what people are avoiding, right? When you start to move something, it hurts.
Yeah, there's some degree of pain. Again, pain is, very individual. Some people experience a lot of pain. Some people experience very minimal pain, even with the same operation. So pain is certainly one of the limiting factors, but there's also a degree of lack of confidence. They're scared to move their joint. And the therapist is there, hands-on, to tell them, listen, it's safe to do this. We're going to do this. We're going to, make your knee move. We're going to make your shoulder move. We're going to make your hand move. And then the patient gains confidence. And with that, they start to recover faster.
Yeah, that's, I think, and then having a nice doctor. The doctor, it's really interesting how you treat that person. All right, they've met you and now you do the surgery, but you're very important in their world and you know that.
Yeah, I think establishing a relationship with the patient where they feel that they trust you and that you're going to do the best for them is critical, and always maintaining open lines of communication for the patient. But definitely establishing that relationship and trust is essential.
Now, some people have, they go to very good orthopedic surgeons, and some never have another problem, and we're going to run out of time, but I just want to tell you, some people, they don't walk as well as others, and I guess that's either their own, maybe it was an orthopedic surgeon that didn't quite do it, or maybe it's they just didn't do their therapy or something, but anyway, this has been a great discussion. I'm so glad. I know I just went on to all things, but I want to ask all the questions that everybody else is asking, and so I took advantage of you.
You're most welcome. It's been a pleasure.
Yeah, thank you. And so if you want to get in touch with Dr. Saing, you would just call 954-580-4080. Thanks so much.
Thank you very much.